glad to see you here. Thank you so much for coming. Most of these events fill in at the very last minute, and then I'm sitting there with the stomach ache saying, oh my God, no one's showing up. So glad you're here. And thrilled that we have Dr. Cherie Simpson here with us. Cherie is a nurse practitioner, advanced practice RN, I'm going to get her titles right, board certified clinical nurse specialist, and she received her doctorate and taught at UT. She got her doctorate in nursing. So she's got wonderful experience, and her research at UT for her doctorate was specifically in what we're going to talk about. It was health promotion for family and friends caring for someone with dementia. So has anyone here had any experience with anyone you knew that had dementia? Is there anyone here who has not experienced someone with dementia? You have never experienced? No mother, father, brother, sister? Wow. Then you're going to learn something new today. And what I have been taught by my patients is that someone traveling down the path of dementia, it's not on them to make it better for us. It's on us to make it better for them. And that's why Cherie is here, is to teach us, because if we know better, we can do better. And part of it is understanding the stages of dementia, how to interact properly, and do the best job that we can for those people that we care about, and they're all around us. So join me in welcoming Cherie Simpson.
Thank you so very much. Couple of things. How many of you are also football fans? So I doubly appreciate you being here, because I know the NFL draft is about to start, and we're really concerned about who that first draft pick is, evidently. I don't know. In the women's basketball, to the Women's Professional Basketball League, they knew who the first pick was going to be. Who was that? Caitlin Clark. So I don't know why it's such a mystery for the guys in the football, but they'll figure it out. The second thing is, it's a sound check. Can you hear me in the back? We're okay? If I start to fade because it is in the evening, please just wave your hand and let me know, because my important thing is to make sure that I go slow enough and loud enough, because I can talk fast and my voice gets high pitched, so I don't want that to happen. The third thing to know about me is this is only a few of the letters after my name. I love school. I have a Bachelor of Arts, liberal arts from Austin College. I could have left there and gone on to physical therapy school, which was my destination, but I love school so much I stayed and got a degree. So then I went to the University of Texas in Galveston and became a physical therapist, so I have a bachelor's in physical therapy science. Then I was working as a physical therapist, and how it goes in healthcare, if you sit around long enough, you're gonna move into management. And so I moved into management, and I got my master's in business administration from St. Edward's University here in Austin. But then, in my career, after about 20 years, I was far enough in management and far enough away from patient care that I was very frustrated with my job. At the same time, guess what happened? My mother got dementia. And so here I was as a healthcare provider that had a ton of background in everything from nursing homes, assisted livings, insurance company, working with doctors, working with rehab. But when it became my mom, all my smarts went out the door, and I was just the daughter trying to find the best course of action for my mother. And I'll never forget sitting in a doctor's visit with her when her blood count was low, and the doctor suspected that she was bleeding somewhere, and my mom already had advanced dementia, that she wanted to do a colonoscopy. And I was like, okay. And she referred us to a gastroenterologist. And the first thing we should have known was, when I couldn't get my mom to sit down in the 15 minutes that the waiting room kept us there, I was in trouble. We got into the gastroenterologist's office, and we started talking about the colonoscopy, and I was like, well, how are we gonna do the prep? And I said, she's in an assisted living memory care unit. They're not gonna be able to help her do that. And he's like, well, we could put her in the hospital. And at that point, I literally busted into tears. Because I could not imagine my mother being in the hospital dealing with an enema or whatever they were going to do to get that stuff out. Because she couldn't drink all of that fluid. She wouldn't understand why. He stopped, as a smart doctor should, and started talking to me about, well, why are we doing this? If you find out something's wrong with your mother, are you going to treat cancer? Are you going to do surgery? And I was like, no. He said, let me tell you this. After your mother dies, and you're sitting at the Thanksgiving table, and you reflect back on this experience, you'll want to know that you did the best you could. And the best you can do is just take care of your mom right now, and this is not necessary. And I was like, and it was at that point I said, man, if I know all of this that I know, and I still run into these situations, how do people who don't know anything about dementia or healthcare do this on a day-to-day basis? So what did I do? I went back to school, and I became a nurse, because you can't get a PhD in nursing without being a nurse. So that's where I got my advanced practice clinical nurse specialist certification as a master's degree nurse, and went on to do my research and teach at UT. So I tell you all that also because we'll have a slide later on. All those letters after my name are my self-defense against Alzheimer's disease. And I'll explain to you a little bit about that. But tonight what we're going to talk about are about the different stages in dementia and trying to help you understand how the disease progresses and a little bit about the difference in the diseases. Now, I also know that Dr. Burleson was the last speaker you had, and he did a fabulous job, correct, as he always does, but he didn't leave enough time for questions and answers. So I am glad to try to help answer any questions he might have left you with, but also leave enough time to answer any questions we can around this subject as well. And so the other thing about this is that it's a unique experience. People do not progress through these diseases in a linear fashion, and we'll talk more about that. As well as, I want to help you understand, as Debbie said, understanding what the behavioral and psychological symptoms are that come with the dementia, and the new term is actually neuropsychiatric symptoms. I just learned that in some research that I was doing, but the old term was BPSD. And then give you some resources so that you can help yourself, help your loved one or your friend or anyone that you know with dementia. Now, when I say that it's a unique experience for everyone, that's simply what this page depicts. Now, again, I don't think you can see my pointer, but do you know who the person is in the middle? Any female basketball fans? Yeah, Pat Summitt. And she's there because she had early onset Alzheimer's, which by definition means that it came to her before the age of 65. And it's a bit of a different animal than late onset Alzheimer's. So sometimes that is a confusing thing because people will say, my loved one has early onset of dementia or Alzheimer's. And what they mean is that they're mild stages of their dementia, but it came late in life. Her disease was different because it came early in her life. So hers is considered early onset dementia. And the other one at the top, recognize that gentleman? Music, yeah, country singers, music. Glenn Campbell. He's there to help me, and both Pat worked while she had dementia until she couldn't anymore. Glenn came out of retirement with Alzheimer's disease and started singing again in public. Again, to show you that in music, it's a different part of the brain that usually doesn't get affected by Alzheimer's disease. And that with the right support, you can lead a full life, even with dementia. And then the others are just examples of people with dementia, except for the person on the bottom left, and that's my mother. And she's my reason for being here. So, and as you can see, just as an example, that is her last Christmas, and she's in advanced dementia. And as you can see, her face is just kind of this blank stare. So she doesn't have the capacity to focus on the camera and realize what's going on. But it's still a cute picture. Now then, my loved one is in 3 different stages of dementia. Is that possible? Yes. And so what I've given you as a handout are 2 different staging tools. They both are common in the sense that they come with 7 different stages. Now, some doctors will just say, it's mild, moderate, or severe. And that is quite common. But when you use official tools, they usually have 7 different stages. One of those tools is called the FAST tool. And FAST stands for Functional Assessment. And when you read over that, it is very much just that. It's going to be whether or not they can put on their clothes, whether or not they become incontinent. And it breaks it down into different stages. The other one is a global deterioration scale, and you'll see Tam Cummings' name on that one. I give Tam credit for that. She didn't develop the scale, but what she did was she elaborated on it. So if you look at that scale for just a second, you'll see that she's added things like how long the stage might last. She's added on the age of what that person functioned as. So you can see clearly, and it's a very depictive way of showing how over time the person with dementia's ability to function declines, like regresses like a child. And so we'll talk a little bit about that as well. And Tam's version, and how many met Tam Cummings or heard her speak? If you get a chance, she's another wonderful speaker about Alzheimer's disease, and has written several books about it, and does it, her books are very much in layman's terms, so very easy to understand. The other thing that Tam has done is given you examples under those different stages in the different areas of cognition. Now, what do I mean by that? Going back to just the definition of dementia, what do you remember from Dr. Bertelson's talk? How did he describe what dementia is? Do you remember? Well, dementia, the way I define it, is that it's simply a measure of how much decline a person has experienced in their function. So what that means is that in normal aging, our brain changes. And when you have change, shrinkage, it means you're going to lose function. And the functions that we lose first are things like our processing speed and our filtering speed. Process is how fast we can handle all the information coming in, and filtering is sorting out what's important to understand now, what's important to hang on later, and what goes into our dreams and gets washed out later. Okay? Now, when normal aging happens and these things occur, what does that mean functionally to you? Senior moments. You walk to the refrigerator, you open it up, and you forgot why you were going in there. You lay down your keys, same place every time. What happens? Where's my keys? And you know why? It's because when you put down your keys, something distracted you like a light in the other room, and you said, I don't remember turning that light on. And your brain doesn't register you put those keys down because it's trying to figure out why the light's on in the other room. Those are senior moments, we call them, but they don't affect your function. You still function like you always do. It's just annoying. And you joke about it with your friends, right? But when other things change, it can be medical things like your thyroid's off balance, you have sleep apnea and you don't treat it. Then those processes get worse and function becomes affected. So in mild cognitive impairment, you may still use your computer, but not to the extent that you used to. You may still drive, but you don't feel as comfortable or safe. But when you progress to dementia, you can't function the way you used to. And it's not just your memory. As you can see on that staging tool, it's language, it's orientation, it's praxis. Praxis means that your body has the strength and range of motion and dexterity to do something, but your brain can't tell you what to do. So if I ask all of you once again to raise your hand if you know somebody who has dementia, please do that. Excellent. So you know what the concept of raise your hand is, and your brain told you to lift up your arm and put it over your head. Some people did it like this, some people did it like that. It doesn't matter, you did it. But when you have dementia, things like trying to put on the seatbelt become difficult. At some point, understanding what a fork is and how to use it, even though they have the strength and range of motion to do it, they can't figure it out. So when you have changes in your cognition, all those different domains, it's considered dementia. But the cause of dementia are these disease processes that Dr. Burleson talked about last time, right? And so you have a bit of an understanding about what Alzheimer's disease is, correct? And a bit of understanding about the difference between Alzheimer's and frontotemporal or vascular or Lewy body dementia. There's many, many others. Parkinson's dementia, there's diseases like Lyme's disease, HIV, that syphilis that can cause dementia. There's alcohol can cause dementia. Those poor young football players out there getting drafted tonight, if they're not careful, they're going to have chronic encephalopathies from the concussions that they have. And the men right now who are dealing with dementia that are post-football players, it's another whole dynamic, because there's nothing like a 250-pound man getting out of control with caregivers that are young women or older women that are 70 to 100 pounds less than they are. So anyway, many causes. Now then, because these diseases don't progress through the brain in the same way on every person, that's why you'll see different pictures, why some people with Alzheimer's disease may be able to talk just like I am now and tell me things like, sure, I still drive. I go down to H-E-B every week and I love to buy a baked chicken and I'll save it for 3 meals and I'll make chicken salad. And I go to Hill's Gym twice a week, and the friend that brought him in was sitting there going, don't drive, haven't been to the gym in 3 years, and the refrigerator's empty unless they bring her food. But yet, short-term memory, her logic, her ability to do other things, gone. Other people may be at the same stage for that part of their dementia, if you found a stage 5, but yet they may be having a lot of trouble with language. They may not be able to find the words they want to say or make complete sentences with good structure of grammar. And so why is that? It's because the disease is killing cells in different parts of your brain. And we know that certain parts of your brain control certain aspects of your cognition. Now then, what can change that? As I said, what lifestyle factors can make a difference why people are in different stages? One of them is education. That makes a difference. Other lifestyle things are how you exercise throughout your life, how you manage your chronic diseases. So lifestyle has an effect on the progression of disease. And then complex interactions. Now, what do I mean by that? Oh, whoops, one more slide. What I want to say is, I don't mean to be negative, but the reality of it is, the importance of knowing what type of disease process is causing the dementia is because sometimes it gives the caregivers a sense of, I want to say, like grounding, like they understand what's happening. Dementia is just too vague. Sometimes it's helpful because it does make a difference in the presentation of the disease. Thank you, Debbie. Put your microphone up. Sometimes it makes a difference in the presentation of the disease. So did Dr. Burleson tell you a little bit how these diseases show up and progress over time? Don't remember that part? I didn't ask him exactly what he talked about. But so just to let you know, in the beginning, these look a little different. Alzheimer's is the type of disease that shows up quietly and progresses slowly over time. It's called a disease of aging because, in fact, I probably have it now. I'm going to turn 65 this year. Get to go on Medicaid. I'm Medicare. I'm so excited. But if I have Alzheimer's, I probably had it for 10 years now. I hopefully will not see the signs of it or the symptoms of it until I'm 80 or 85 if I'm really late. But my family doesn't have that good of a history, given my mom's history. The difference is, hopefully, the things that I've done differently than my mother did, like my education, my healthy lifestyle, compared to hers, so that I won't see it until later. But oftentimes, when families are given the diagnosis of Alzheimer's disease and they start talking about it, they start to do like we did with my mom. When my aunt said, oh yeah, 4 years ago when your mother came up here, she got lost going to the lake, and she'd been to the lake 1,000,000 times. Aunt Jane never told me that one. Or people will say, yeah, he was having trouble at work and we just thought he was overstressed. But it turns out those little signs of the dementia or beginnings of the Alzheimer's disease was starting. And then people find out later on and start to reflect back. Vascular dementia is usually a stair-step kind of progression. Because it is vascular, it usually oftentimes shows up after an event. Someone had heart surgery, someone's had a small stroke, someone's had myocardial infarction and had some time without oxygen. So vascular will stay kind of on a stage or level until another vascular event will occur, then they drop in function, and then another occurs. So it's a bit of a stair step, and sometimes comes on more suddenly than Alzheimer's does. The next one, Lewy body, oftentimes looks like Alzheimer's, but the facts are that oftentimes it shows up earlier than Alzheimer's does, and it oftentimes shows up with hallucinations as some of the first signs. And they also have a fluctuation that Alzheimer's doesn't have in their cognitive abilities. So some days they'll be like sharp as a tack, and the next day can't remember what they had for breakfast. But the hallucinations are an important factor. And the last one, frontal temporal dementia, oftentimes shows up as a very different personality change before the memory problems start. So my favorite story about that is I was treating the wife of a person who, she was very depressed because he had left her and she thought he had a midlife crisis. He moved to Mexico, got a mistress, bought her a condo and all sorts of stuff. And when the frontal temporal developed and got worse, she kicked him out and sent him back to Texas, where his wife then had to take care of him as the disease progressed. She had a hard time getting over that one, let me tell you. So anyway, so knowing what the disease makes, where it comes from, where the dementia comes from, helps you understand what the progression might look like. And from a clinical perspective, there are some importances because, like for a Lewy body hallucination, I can't give them the same medicine I would for an Alzheimer's hallucination. And for a frontal temporal, I can't give them the same medicine that I would for Alzheimer's. So there are some important factors about that. But I tell you all that to say, as the disease progresses, at the end, this global deterioration scale, which is made for Alzheimer's disease, in those last stages, everybody looks the same. That's the problem. After time, everybody looks the same. I mentioned how you can take care of yourself now, how you can tell your children if you have Alzheimer's in your family or other dementias, how you can help take care of yourself, and lifestyles have been shown to have an impact on the disease happening and progressing to a small percent, not a large percent. And it doesn't mean if you do all of these things right, you're going to prevent having Alzheimer's disease, but you stand a better chance of helping yourself as well as helping to keep your brain as healthy as you can. So again, if one has chronic illnesses, managing those. If you're diabetic, please, that's the most important disease to manage. But all the others are equally important. High blood pressure, because that can lead to vascular disease, as well as asthma, COPD. All of those diseases have an impact on your brain. Now, exercise, it doesn't hurt that I was a physical therapist before I became a nurse, because there's no evil in exercise. And in fact, exercise is one of the things that we know actually improves cognition in our brains. They don't totally understand why now, and it's not the endorphins and the enkephalins, it's another BNP, and if there's any bioscientists in here, you can help me out. But there's another hormone or production of juices, I call them, that help the brain function in cognition with exercise. Nutrition, more and more research is coming. Yes, sir?
Can I ask a question?
Yes. You can ask the question anytime.
Why is diabetes more harmful than others?
Because when diabetes is out of control, it affects so many organs. You know, it's very traditional to think of somebody with diabetic retinopathies or skins that won't heal. But all of that happens to many organs, including the brain. Nutrition. I was going to say, more and more research is coming out about the gut biome. Have you heard of that one yet? Yes? Yes. So the gut biome is about the natural flora that is in our gut. And that natural flora in our gut helps regulate our immune system. And when the immune system isn't regulated well, one of the big things that happens is inflammation. Inflammation is the root of a lot of evil and a lot of disease processes. And they do believe that inflammation is a big part of Alzheimer's disease. They just can't figure out what part of the process is when it starts and how it affects it. That's one of their big goals in research right now. But from a lifestyle perspective, the Mediterranean diet is always recommended as your best bet in a healthy diet. But there's also diets that are called anti-inflammatory diets that you can Google that would tell you what the right foods are and the right special fats to eat, things like that. Now, I can't tell you to go out and get a new probiotic with a lot of acidophilus in it, and that's going to save you from Alzheimer's disease. We are way far from that. And I can't even tell you right now to go get a really good probiotic and it's going to protect you from Alzheimer's disease. But it ain't going to hurt you. So probiotics is a positive thing to do for your gut biome. And last but not least, you thought I was kidding about the education thing, right? Has anyone ever heard of the NUNS study? Yes. The NUNS study is one of the most fascinating things that I've ever heard of, and it's a situation in which a convent of nuns donated themselves to science, and this one particular researcher was interested in stress, and he found the ideal subject matter in these women because they all worked in the same environment, they all had the same amount of stress, they all did the same level of activity, they all ate the same food, they all prayed and meditated at the same time, so they were very, very, very much the same. Every year they did biomarkers and they did cognitive testing, and when the nun died, they had donated their brain to science, so they were able to do an autopsy and slice that brain open, and that used to be the only way we diagnosed Alzheimer's disease. And what they found was that on the MMSE, Mini Mental State Exam, which is a screening tool that we use, Sister Marguerite might have scored a 12 when she died, which is pretty advanced in the dementia range. But when they did an autopsy on her brain, she didn't have a lot of plaque, not a lot of the plaques that you expect to see. So what the heck? But yet, Sister Teresa, who scored much higher, gave her an 18, when they sliced her brain open, had a lot of disease load in it. What made the difference? One of the things they found out is when they went back and reviewed the essays that they wrote to enter the convent, the women who performed well with higher disease load had richer essays. The wording, the thought process, the education level was higher. So that's when they started to realize that education helps build neural networks that are protective against those dying cells. Any questions about that? Lifestyle, etc. Yes, ma'am.
Does the education need to be over your whole lifetime, or you got it to 25 and
Yeah, so the interesting thing is that we are born with more brain cells than we can ever use. And there's a time in our lives, in the early part of our lives, where we're building those neural networks. And then at a certain time, we stop building them and cells start to die, kind of in our 30s. But it doesn't mean you can't teach old dogs new tricks and you can't build neural networks. So yes, staying educationally engaged, learning new things, and what they'll tell you is don't do the same thing all the time. If you're a crossword puzzle expert, you built that neural network. Go try Sudoku, go try a foreign language, go try an instrument. Do something different to build a different neural network. I had a question back here. Yes, ma'am.
Have you read any studies on the
Can't
gut
hear.
brain
I'll repeat it.
axis?
I'm sorry?
Have you done any studies on the gut-brain axis?
Yes, that's what I'm saying. That gut-brain biome is being studied right now. And they do believe that there's a connection between anxiety, dementia, cancers, and I don't remember if depression was one, but definitely anxiety is connected, which is very, we won't go, that's another whole lecture. Yes, sir.
I have a question about language, but I can ask it at the end.
Go ahead.
Why don't we hold till the
Okay.
end, just so we can get you on
Do
your,
my slides.
on your 30-minute slides and get on to questions.
There you go. All right, So complex interaction. This is a very busy slide. I apologize, we'll break it down. But what it says at the top left, and you have a copy of it, is neurodegeneration associated with dementia. Changes in the ability of the person with dementia to interact with others and their environment. Disruption in neurocircuitry. So that's what's going on with the patient with dementia, which leads them to an increased vulnerability to stressors, which then leads to these behavioral and psychological symptoms. So this is the pathway of how it happens. And the things that influence the increased vulnerability to stressors on the left are the patient factors, we'll go over those, the caregiver factors, and then the environmental factors. So this is a theory of why these behavioral and psychological symptoms happen. Now, what are they? It depends on who you talk to, but there's at least 9 to 11. And these are things like emotional changes, depression, agitation, anxiety, irritability, to other behavioral things like wandering, disrupted sleep, having the psychosis that we mentioned, which can be hallucinations, but the most common one that I see probably early on is paranoid thinking, that somebody's stealing from them, that the maids come in and taking their jewelry, when in fact they hid their jewelry and they just can't remember where they hid it, and it's usually found. And the last is inappropriate behavior, and I love to tell the story, because I use a lot of stories about my family. My father-in-law was a retired Presbyterian minister, but at the same time a very opinionated man, and in some ways very bigoted. And I can say that now because everybody in the family knows it. And he thought lots of things, but he knew better than to say it, right? And so he had a caregiver. We finally talked his wife into bringing in caregivers, and she was obese, and he always had a thing about women being overweight, to the point where he would tell his daughter, "Have you gained weight?" You know, nice things like that. So he was sitting with his caregiver, and he looked right at her, and he said, "Is your sister as fat as you are?" Now, she had no idea how to handle that, which tells you the agency that brought her in didn't do a lot of good training. She actually left. But at the same time, his favorite place in the whole world was IHOP, and they would go there twice a week. And the problem was he loved children. And so any toddler, he would walk up and try to pick them up and kiss them. And you could see the parents go, "Oh my God, stranger danger, dirty old man." And he had no concept. So those are inappropriate behaviors where the social filters, the social cognition has eroded. And sometimes that happens earlier in the disease than others. Any questions about what those are? Let me tell you the hardest one is apathy versus depression. Depression we can treat with medication, apathy we can't really. Sometimes we try to get a stimulant to try to boost it along, but apathy is a hard one. Especially hard, when I did my research, it was one of the things that stressed caregivers out the most. Because especially in a spousal relationship, especially if you had a man who had been a workaholic and came home at night and expected dinner, and now he's got dementia and the wife's got him side by side with her all the time, and she asked him, "What would you like to do?" And he goes, "Whatever you want." "What would you like to eat?" "Whatever." No thought process, no planning, no thinking about what they want, just kind of apathetic about it. So that was one of the hardest ones for caregivers to bear. But by far the agitation up to the point of aggressive behavior is the most difficult one that we try to manage, because we've got to keep everybody safe. Family members safe, patients safe, paid caregiver staff safe. So that theory that I showed you, that diagram, involves two different theories itself. One being this progressive lower stress threshold, which means that as the disease progresses, they can't regulate as well as they did before. So it becomes when they get overtaxed that they react. Versus the other theory is unmet needs, which means they're acting out because they need something that we haven't addressed. Sometimes it can be simple, like they've got to go to the bathroom. Sometimes they're hungry. Sometimes they're in pain. And sometimes it's emotional, like they're lonely and they can't understand. One of my favorite stories was when I was doing research and I visited with this daughter, and she had a father who throughout his life had schizophrenia. So they were estranged until he had a stroke and vascular dementia, and she was the only one left to take care of him. So he lived in her home, and what would happen is he would go to get a shower, he'd come out, and he'd start asking for his wife. And she would say, "Dad, she's been dead for 15 years. And That was not the right response. We chatted and we talked about the unmet need thing, and she had a breakthrough. Next time he did it, she stopped and said, "Dad, why do you need Mom?" He said, "She's the only one who knows where my pajamas are." Clear as a bell. So what he was looking for was his pajamas, and he couldn't find them, but he knew his wife would know where they were. So decreased stress on daughter, decreased stress on dad. Now then, sorry? So let's talk about the patient factors. As I just mentioned, unmet needs is one of the biggest causes for why behavioral actions are taken. And they also can involve medical situations. So we have to be aware that behaviors will occur with things like an infection. So whenever a patient tells me one of their loved ones with dementia has had an acute change, their dementia got really bad all of a sudden and they became psychotic, or they started peeing where they're not supposed to, I say, let's get a urine, because it's oftentimes a UTI. But it doesn't just have to be a UTI, it can be an infection from a respiratory infection. We've had pneumonia show up, so just realize that there can be medical reasons why there's behavioral changes. We talked about delirium. We talked about unmet needs. The last thing I want to just mention is one of the strategies for trying to figure out those needs is to look at a behavior that's repetitive and look for the antecedent. So ABC stands for antecedent. What's the trigger for this? Is it every time dad goes from the facility out to lunch and comes back in, the hours after that he's confused and hard to get along with? So looking at what can be the trigger is another way of trying to figure out how to help decrease the behavioral issues. Now then, here's some of the things that can make it more difficult, which is about environmental. The idea that the environment is too large, they're in a big space, they're outdoors, they're not used to that can make them confused. It could be too much clutter, it could be excessive stimulation. I just had the story where one of my clients, the grandkids came over this weekend, 4 of them, 13, 11, 7, and 4. And she was a total mess. She loves them, but it was just too much chaos for her, so she's having a hard time settling back down. No orientation or information or cues. So oftentimes, again, when people seem very confused, if you just redirect them, give them a task, it can help calm them down and help that behavior. Sometimes the task is too complicated, it has too many steps. Again, to help bring this point home, I had a husband who said, she can't even set the table anymore. And I said, okay, let's break it down. What does set the table mean? You gotta remember what the table's for, that you're gonna eat there. You gotta remember where the plates are. You gotta remember where the silverware is. You gotta remember where the plate goes on the table, where the silverware goes in relation to the plate, and oh my gosh, do you need napkins too? So there's a lot involved with set the table. And so breaking down tasks is sometimes another way to help decrease confusion and irritated behaviors. And sometimes the tasks just need modification. Again, doing it step by step or making it easier, starting the step for them and letting them finish it are all different ways to do it. Bathing. You can read there all the possible causes for why bathing might be a problem, and you can read there all the coping strategies that go with it. This is how common it is. This is an entire book called Bathing Without Battles for Patients with Dementia. You can get it on Amazon. This is one of the most common problems that people have. But the first thing you need to know is that it's okay to give up, that you don't have to have a bath every day. In fact, as we age, it's probably okay we don't take a bath every day to protect our skin. And so it's really important from a hygiene perspective that, as we call it, the down south stays clean. But the whole body doesn't have to have a bath every day. So making adjustments to things like that are important. Communication. If you have a pen and paper with you, write down the name Teepa Snow. Teepa Snow is an occupational therapist, and you can Google her on YouTube. And she provides wonderful examples of how to interact with patients with dementia. And the most important thing is to understand about where your position is in relation to the person, how you make contact with the person, how you use touch to help the person, how you understand that, especially in Alzheimer's disease, their peripheral vision goes from. So that's why my mom looked the way she did, because she didn't see anything out there and recognize it. And so other things like making sure there's no distractions. When I was working in facilities and I'd go in and talk with a patient with dementia, the first thing I did was turn off the TV because it was just rambling. The person wasn't watching it was just noise in the background. But making sure there aren't distractions. Giving them concrete terms. So again, as you see on the handout, as it progresses, the dementia moves more and more childlike. So I always ask, if you're a grandparent, you've been parents, do you ask a 2-year-old, do they want to take a bath? They're going to say no. And so the important thing is to say to a 2-year-old, do you want your cookie before your bath or after your bath? Because the bath's coming. Do you want a cookie before or after? Same thing with patients with dementia, give them choice. By giving them choice, you keep their dignity, but you give them concrete options. So those are other ways to avoid confrontation. And the last one is the caregiver. How many of you who have a loved one that has dementia has caused you frustration where you might have said something you regret it after you said it because you lost your temper? Don't raise your hands, I don't need to know. I know the experience, believe me. And so caregiver stress is one of the main problems because it leads to poor communication, which then escalates the situation. This is a model of caregiver stress. It's the one I worked with in my research, and basically it says there's things in your background that may impact how you do caregiving, that your primary stressors are things like actually giving the care, but then there's secondary stressors like giving the care causes you to give up all of your social activities, causes you to give up going to your own doctor's appointments, and through that it ends up in depression and other poor health outcomes, but there are mediating coping skills that can make it all better. So we're going to talk about some of those. One of them is the stress busting program. These are the 3 things I'm going to show you are research-based, evidence-based training programs that have been developed mostly by nurse researchers. But this one is one that's available that's about helping the caregiver reduce their stress. The other one is Savvy Caregiver. This one is more about training you on basic skills to help interact with the person with dementia. Versus the last one, Powerful Tools, is more about teaching you again how to be a strong caregiver, how to interact with doctors, how to make plans. The last 2 Powerful Tools in Savvy Caregiver are available to you through Caregiver U done by AGE and St. David's Foundation. So those are things that are available in our area. Other resources online, the Texas Alzheimer's Org does great presentations. AGE of Central Texas, great presentations. But then if you're an online learner, there's great things through the Alzheimer's Association as well. The end. That's my mother and my sister.
All right, now we're going to take questions, as many as you have.
Oh, yes. What, I'm the only one with a problem here. Well, what is the relationship between hearing aids and Alzheimer's?
Great question. Great question. I always ask.
Good answer.
My answer is always, if you can't hear it, you can't learn it.
Hey,
Right?
wait a minute. Aim at them. Don't aim at them. Aim at me.
If you can't hear it, you can't learn it. If you can't hear it, what do? You start to withdraw, you ignore, and it can make it look like you have dementia when you really don't. What you have is the inability to hear the information and to process it. And so hearing aids are important. They are, next to CPAP machines, the most expensive unused piece of health equipment we own. It happens all the time. But if you don't hear it, you can't bring it in and learn it. Another thing to know too is that a normal aging change to your hearing is consonants. And so again, it may look like you have dementia. When you don't, it's just a hearing issue. And my favorite is, Mom, did you take your pill? I paid my bill. What are you talking about? P's and B's, C's and G's. They can all be confused. And so it sounds like you're answering a question that's out in the Netherland, when in fact you just misheard what they said.
Did I understand you to say just try another brand? You know, if the one you have isn't working, can you pay the same amount or pay twice as much and have a better chance?
You know, that's really a good question for an audiologist because
Or home?
For an audiologist is the person who tests your hearing and helps you figure it out. Yeah, that would be the best, because I know hearing aids need to be in your ears.
Have you ever met anybody who loves their hearing aids?
Yes,
I love
ma'am.
my hearing aids.
Oh, there's somebody who loves their hearing
I love
aid.
my hearing aids, and my mom had hearing aids before I knew what they were, what they were like. She got a very cheap pair, and it was horrible. So all I would say is, get the testing, pay the money. I wake up in the morning, I put my hearing aids on, I hear everything. When my phone rings, it goes right to here. There's advantages. Hearing aids are fabulous, but
They keep
go
marriages
to a
together
good
too.
audiologist.
They keep marriages together too, let me tell you that. Yes, ma'am.
I just have a question on paranoia
Yes.
and outcomes with that or treatment for it.
Okay, so the question is about paranoia. Is there treatment options for it? Is there good outcomes for it? It really depends on the disease process. In Lewy body, I hate to say no, it's not great. Because the paranoid delusions, hallucinations of Lewy body are, when you give them the antipsychotic that I would normally give in Alzheimer's, and I can talk about that, it makes it worse. And so trying to minimize the stress of the hallucinations and delusions is what we try to do through other medications, like putting on an antidepressant to try to help calm them down. There are other medicines that kind of help kind of dysregulate them a little bit. But it's not usually curable. The hallucinations aren't. In Alzheimer's disease, sometimes we can get them under control. I have a person right now who's delusional, and she thinks that her husband is having an affair, and she's going around telling the whole world about it. And the poor thing about the gentleman is that the one thing he values in his life is truth, honesty, and loyalty. And so he's constantly fighting with her to tell her that he's not having an affair. That does nothing but aggravate her, because when you have a delusion, it's a fixed thought. There is nothing that you can say that convinces them that they're not. When they have hallucinations, sometimes they recognize that what they're seeing or feeling or hearing is not real, and sometimes you can help them by saying, honey, there's nobody there, it's just you and me, and we're okay. But the most important thing to do in either one, if you have delusions, then the most important thing is acknowledge what they're saying, give them feedback that you understand their emotion, and then try to do something different. And so one family, as soon as he started to ramp up, she's like, honey, do you want a Heath bar? And feeding him helped. I'm sorry, I'm right in front of the camera. Yes. Yes, ma'am.
Hi, my husband has probably late-stage Parkinson's dementia. And the one thing I was reading on here that I didn't know about is the skin. Can you describe how that shows up, if there's problems with the skin breaking down?
And that's in the late stages you're talking
Yes,
about?
yes.
So in the nursing world, I hope you guys are going to be here for the long term. Sorry, these are long stories. In the nursing world, it's a very, very bad thing to let a patient develop a pressure ulcer, which means they have laid on or sat on one space to the point where the pressure from the bone has shut off the circulation to that skin area, and the skin starts to break down. It starts out as a red spot, then the skin starts to die from it within, and the next thing you know, you've got a big, bad wound that's hard to heal. But in the late stages of life, not just dementia, it's now beginning to be a consideration that that is just a stage of the end of life. Because one, circulation isn't as good, skin quality is not as good, they've lost fat, so there's not as much pressure, cushion between the bone and the skin, as well as the person is going towards the end of life. One of the things that happens, especially in dementia, is people stop eating, or they eat and they're still losing weight even if they're eating. And so one of the things that matters in healing is your albumin level. And albumin is something that comes from eating healthy and lots of protein and things like that. So it's sort of a consequence that's coming towards the end of life. Like we talk about at the end of life, you'll start to have discoloration of their distal extremities because the blood's not flowing there. It's trying to stay closer to the organs, etc. So that's.
Well, this is on his face, and it's like broken out, and it's red, and
Is he picking?
No.
He's not picking?
No, he doesn't do that. I don't.
That may be more of an autonomic response. I would talk to his neurologist about that, because that's one of the bad things about Parkinson's is the dysregulation of the autonomic system. And so that creates all sorts of weird things, like inability. I have 3 women with hot flashes, all have Parkinson's. And they try to treat it as hormonal, but it's not hormonal. So. Yes, sir.
What role do support groups for caregivers, what role can they play in helping the illness?
For the caregiver, they can be huge. They can be huge. I'll give you one more example. I was doing a focus group with about 10 caregivers. Some of them that came were caregivers that had been caregivers for a long time, very engaged in support groups. 2 of the women were new to the world of dementia care. And when they came and the questions that we asked, they told stories about their experience. One woman really cried. I mean, she broke down and cried because she said out loud, I thought I was the only one going through this. And to be able to hear the other stories and to know that other people have done this and have ideas about how to manage it was very helpful for her. Now I have other people who will tell me they hate support groups because they don't want to sit and listen to what's coming. They don't want to hear somebody's story of how things are going to get worse. So support groups are very helpful if it's something that you can take value from, because that's what you really do is you share your journey. And the journey is long and the journey is hard, and sometimes it's helpful to hear from people who have been down the road before you. Yes, sir.
This is a different kind of question. I'm curious because some of my studies have indicated that if you learn a foreign language before 10, it's stored in a different part of the brain than if you learn it after 10, and after 10 it has a harder recall. So my question is, what if you have several languages? I speak 3, I've studied 5. Once the brain starts to shut down, are the languages stored in a part that's different from what dementia is going to deal with? Because often when you're studying languages like this, the other language pops up as your answer before the one you're looking for. So I'm wondering what goes on in the brain when dementia starts to be there.
That's a good question, but what I have seen anecdotally is that normally your first language comes back. So that, for instance, if I have people who are Spanish speaking first and English second, Spanish will be what they revert to as the dementia progresses. I don't know about multiple languages and which one would come up first, sorry. So I don't know that one.
Any other questions?
Any questions Dr. Burleson didn't answer that I could try?
Well, I've got one that dealing with, as not a caregiver, but as a casual acquaintance to somebody, and that you see often, and like, is there certain things you should be thinking about and how you deal with them? Like I had a person today who sort of, I don't know how many times. Do you live here?
Yes, that's probably, so what I would say, if you're a casual friend of people who are dealing with dementia, spending time with the person with dementia so that their caregiver could take a break is huge. 30 minutes, an hour, a couple of hours, take the person with dementia out for coffee, whatever you can do to give that caregiver a break would be probably greatly appreciated. When you're interacting with somebody who has dementia and they're asking multiple questions, just put your patient's hat on and just answer the question. And don't say, I've told you that 3 times. Because all that does is make the person either upset that they've made a mistake or upset that you're questioning them. And so it's really not helpful. Yeah, it's aggravating for the person with dementia to be told that you've been told that before. Another example is, again, using my family. My father-in-law and my sister-in-law, who's the oldest daughter, their relationship was a little contentious. It wasn't horrible. They were never estranged or anything, but there was just this little edge to them. And so Becca would constantly say, Dad, don't you remember? Dad, remember that I did da-da-da-da. And finally I just pulled her aside, I said, Beck, if he would remember, you wouldn't have to tell him again. So just tell him what you want to tell him and don't remind him that you've already told him. So simple conversations like that make a huge difference in how you interact with people. Huge difference in how you interact. Any other questions? I know it's getting late.
Well, I just want to say thank you.
Oh, you're so welcome.
Wonderful to have you here. And the last thing is, the slides were not handed out, they will be put on the portal. So that anyone that wants to go through the slides and see the detail, it'll be on the portal as well as the speech. And again, many, many thanks.
You're welcome.